Okay, I have a short paper to write. Okay. If anybody is interested, you raise your hands. If you're not interested, then I will choose somebody. If many are interested, I will choose by law. So we introduced the CSF beta amyloid tau, no? And we have been doing it. So we have maybe around 20 cases. So taking of writing it up. What are the clinical impression, neuropsych impression, MRI, and how did this match with that? In how many cases it helped us make a diagnosis, change the treatment, all that. Okay. But whoever decides to do it has to do it quickly. Means there's some pressure on writing it up. So maybe 10 days or 2 weeks like that. Okay. So at the end of this class, you people tell me whether anybody wants to write. I don't have time to write. I want one of you to write. If you can't, then I will pick some butter. If more than one person says yes, then we'll put pause. Okay. Shut.
Good morning, everyone. Today I'm going to present a seminar on cavernous sinus. Introduction. Cavernous sinus is situated in the middle cranial fossa. It is one of the paired dural venous sinuses. It sits on the both sides of the sphenoidal bone and pituitary gland. It measures approximately 1 cross 2 centimeter in size.
You know, there's 1 into 2, right?
Yes.
Okay.
The cavernous sinus.
So which is 1 and which is 2?
Sir, anterior posterior is 2 centimeter and transverse diameter is 1. It is situated in between the 2 layers of the dura mater, that is endosteal and meningeal dura mater. It works as a channel and helps in the passage of internal carotid artery. Coming to its boundary, it's mainly formed by roof is formed by internal carotid artery and optic chiasma. Floor is formed by the foramen lacerum. Since there is entry of internal carotid artery, anteriorly it is formed by superior orbital fissure. Posteriorly by the apex part of the petrous temporal bone. Laterally by the third cranial nerve, fourth cranial nerve, ophthalmic division of trigeminal nerve, and uncus part of temporal lobe. Medially by the pituitary gland and sphenoidal air cells. And it contains mainly internal carotid artery and cranial nerve 6th. Coming to this boundaries, as I told, it is a channel which is situated in between the endosteal and meningeal dura mater. This continuous green line is the endosteal dura mater, whereas this intermittent line is the meningeal dura mater. Medially, it formed by the superiorly by pituitary and inferiorly by the sphenoidal air sinuses. Superiorly, here it will be optic chiasma and internal carotid artery, as it runs upwards and divides to produce ACA and MCA territory, and laterally formed by third cranial nerve, fourth cranial nerve, that is trochlear, and first part of trigeminal nerve, that is ophthalmic nerve, second part maxillary nerve, and outside of this cavernous sinus is the mandibular nerve.
So it is sitting in correct order only, isn't it?
Yes.
3, 4, V1, V2. Later.
Yes, this is content is the internal carotid artery, and inferior lateral to this internal carotid artery is the abducent nerve. This is the MRI, Fiesta MRI, showing the cavernous sinuses. As you can see, this is the pituitary, and this is the sphenoidal air sinuses. This, as I told, it is an internal carotid artery superiorly and optic chiasma.
Where is optic chiasma? You want to get it now.
This.
Which one?
This.
Which one? White or black?
Sir, white.
White. That is optic chiasm.
Yes.
Why do you think white should be optic chiasm? That horizontal thing is the optic chiasm. Okay.
Yes.
And what about above that?
This.
What is that? Does it not look similar to the internal carotid artery signal?
Yes.
And what is go laterally? Laterally above that. What is that?
This.
That is MC.
MC.
And the other one is
AC.
Okay.
Yes.
Those are flow void.
Yeah.
Blood is black.
This is internal carotid artery. It's superiorly also internal carotid artery, and this is third cranial nerve. This is maxillary. Sorry, ophthalmic division of a trigeminal nerve, and here is the maxillary division of trigeminal nerve. In this diagram,
it is seen better in that.
Yes, at this image.
3, V1, V2. And the internal carotid artery is passing through it is curving upwards, isn't it?
Yes,
in that image.
Yes.
Going from down to up.
Coming to the channels which cavernous sinus communicates, mainly it has got incoming channels, outgoing channels, and interconnections. So incoming channels is mainly received from orbit, brain, and meninges. From orbit, there are three veins, that is superior ophthalmic vein, inferior ophthalmic vein, and central vein of retina. This superior ophthalmic vein act as an emissary vein. It acts incoming as well as outgoing depending upon the pressure and the gravity. Second one is from the brain. We have superficial middle cerebral vein and inferior cerebral vein. From meninges, we have spinopalatine sinuses and middle meningeal sinuses, mainly the anterior tributaries.
Spinopalatine, isn't it? Yes. It is spinopalatine or something. Spinopalatine.
Yes. Outgoing channels are superior petrosal sinus and inferior petrosal sinus. This superior petrosal sinus will communicate with transverse sinus. Inferior petrosal sinus will communicate with sigmoid sinus, which in turn communicate with internal jugular vein. As I told earlier, superior ophthalmic vein act as emissary vein. It act as outgoing channel also. Coming to interconnections, there are two interconnections. One is anterior intercavernous sinus, and another one is posterior intercavernous sinus. Some parts of posterior intercavernous sinuses form basilar venous plexus. This extends beyond the foramen magnum and connects with the Barton's or vertebral plexus, and this channel is responsible for the metastasis from prostate to the brain. So coming to this diagram, which shows venous drainage of the skull and brain. This is a cavernous sinus, which receives the tributaries from superior ophthalmic vein, inferior ophthalmic vein, and whereas posteriorly it drains into two parts, that is superior petrosal sinus, which in turn drain into transverse sinus, and inferiorly inferior petrosal sinus, which in turn drain into sigmoid sinus, which in turn drains into internal jugular vein. Whereas some part it is communicated with pterygoid plexus with the help of emissary veins through foramen ovale. This importance of pterygoid plexus is this will communicate with the facial vein, deep branches of the facial vein. So any infections from the facial area, that is around the dangerous area of the face, will the infection will drain either from these deep branches of facial vein to pterygoid plexus to cavernous sinus, or from superior ophthalmic vein, which act as an emissary vein and drained into cavernous sinus and act as a nidus for infection. This is a simplified diagram showing what all are tributaries cavernous sinus will have. So incoming channel, as I told earlier, superior ophthalmic vein, inferior ophthalmic vein, and central vein of retina. And meningeal and brain branches are spinopalatal sinuses.
Spinopalatal, there's a sinus like that. Spinopalatal. Spinopalatal is closer.
Frontal and anterior trunk of the middle meningeal vein, superficial middle cerebral vein, inferior cerebral vein, they will drain into meningeal and brain branches. Whereas posteriorly it will drain into superior petrosal sinus and inferior petrosal sinus. And as I mentioned earlier, pterygoid plexus are communicated with the emissary vein from foramen ovale. As I mentioned, the venous drainage of the face, some deep facial vein will communicate with the pterygoid plexus and serves as an infection for helps in carrying infection from facial dangerous area of the face to the cavernous sinuses.
You tell what are the dangerous areas of this?
It is the lower 1/3 of the nose and the upper part of the lip. This area is called as a dangerous area of the face. So any trauma or infection around this area, like boil, furuncle, that infection will be drained to the facial vein. Then from facial vein, they are drained to cavernous sinus. So
why are you repeating the same thing in different ways? It is like some song will have the same stanza repeated again and again. One good diagram, one good description, and we are done. Now you are confusing us by showing it in different ways. Go back. Go back. This is a very good diagram, which is genuine anatomy. You can also imagine how things are moving and where they are moving. Next one, unnecessary. This is may not be, it may be simplified, but it is visually not easy to connect. Because other one we know the anatomy and we can understand. Now you gone to full text. Next one, it's like degrading. From good to bad to what? Just because you collected many images doesn't mean you have to put all of them. You select which one is conveying things better. Okay, now you have one more image. Okay. Okay, this is a different angle, so you can tell this.
From superior view, sir. That was from lateral view. Cavernous sinus, from orbital branches, a central vein of retina, inferior ophthalmic vein, and superior ophthalmic vein. Interconnections, anterior and posterior intercavernous sinuses, and from meningeal and brain branches, superficial middle cerebral vein, inferior cerebral vein, and middle meningeal sinus vein will also drain here, and superiorly. Posteriorly by superior petrosal sinus, inferior petrosal sinus, and some part will communicate to produce basilar venous plexuses, which will drain beyond foramen magnum.
So you go back, no, go up. You see the superior orbital fissure, no?
Yes.
Which are the veins coming through that?
Inferior ophthalmic vein and this one, sir, superior ophthalmic.
And sphenoparietal sinus also through that?
No, sir, it's outside.
It's not inside that.
No.
Okay, and then the central vein of retina is coming through? So what is it coming here? Central vein of retina. Upper.
Sir, it's below the cavern.
No, through which foramen is it coming out? Which foramen the optic nerve comes?
Optic canals. Then next we'll see what is a superior orbital fissure. From superior orbital fissure, it's mainly divided into three parts by a ring that is formed by the muscles of the orbit. These are superiorly it mainly contains three nerves and one vein. That is trochlear nerve and lacrimal and frontal nerve. These are the branches of ophthalmic division of trigeminal nerve. And superior branch of ophthalmic vein, and in center it mainly contains superior and inferior branches of oculomotor nerve, mesociliary nerve, which is intern is a branch of ophthalmic division of trigeminal nerve, trigeminal nerve, and inferiorly mainly by inferior branch of ophthalmic vein. Coming to optic canal, which contains mainly optic nerve and ophthalmic artery. So what is the importance of this diagram is how to differentiate between the cavernous sinus lesion, superior orbital fissure syndrome, and orbital apex syndrome. So in superior orbital fissure syndrome, you will have the third, fourth, as well as the fifth ophthalmic division of fifth cranial nerve palsy. This include, if these features are there, then it is superior orbital fissure syndrome. If along with these cranial nerve entrapment with the optic nerve involvement is there, then we call it as orbital apex syndrome. So how to differentiate between orbital apex, superior orbital fissure, and transverse syndrome is mainly involvement of the V2 segment. V2 is not exiting from here, sir. It will exit from the inferior orbital fissure, sir. So superior orbital fissure will only involve third, fourth, sixth, and V1 segment, sir. So orbital apex syndrome, 3, 4, 6, V1, and along with that optic nerve is involved. Whereas orbital cavernous sinus syndrome, 3, 4, 6, V1, V2, these are the involved, sir. V2 is the differentiating feature between cavernous sinus and superior orbital features.
And the optic nerve is the differentiating feature
For optic orbital apex syndrome.
Which of these is called Tolosa Hunt?
So Tolosa Hunt is nothing but a differential for cavernous sinus syndrome only, sir. It is just a granulomatous inflammation, non-infectious cause of part of the cavernous sinus and orbital apex. There it's the only granulomatous inflammation will be going on.
No, 1 and 2 are called Tolosa Hunt syndrome. No, this one. Those three entities are there, no?
Yes, sir.
Which of this is also called as Tolosa Hunt or Tolosa Hunt syndrome?
Different.
Is which one?
It's different, sir.
It's another entity.
Yes, sir.
Fourth entity.
Yes, sir. That I will be discussing in the last. This is the same diagrams. Cavernous sinuses, third, fourth, sixth, V1, V2, and some part of sympathetic fibers are also involved, but it is very difficult when third, fourth, and sixth are involved. Horner syndrome difficult to diagnose. And orbital apex syndrome, third, fourth, 3, 4, 6, V1 segment, and optic nerve is involved. Superior orbital fissure syndrome, 3, 4, 6, and V1 only. Same. So any patient with multiple cranial nerve palsy with pupillary defects are there, we have to differentiate V1 segment, V2 segment, and optic nerve. So if V1 and only V1 is involved, then we will label it as superior orbital fissure syndrome. V2 is involved, we will label it as cavernous sinus syndrome. If optic nerve is also involved, then we call it as orbital apex syndrome. Coming to cavernous sinus thrombosis, it is a rare disorder with 4.5 cases per million per year. It is least common dural venous sinus thrombosis, accounting for less than 1.5% of the CVTs. Etiology, it's mainly the continuous spread of infection, mainly by Staphylococcus aureus, infection from the paranasal sinuses, dental abscesses, orbitocellulitis, and middle third of the face, that is dangerous area of the face. And other causes include cavernous sinus compression, mainly by trauma or tumor, and thrombophilic conditions like protein C or S deficiency, oral contraceptive use, malignancies, and pregnancy. And in 25% cases, this idiopathic cause is not known. So as I told earlier, pathogenesis, mainly cavernous sinus drains the superior and inferior ophthalmic vein and superficial cortical venous anteriorly. Cavernous sinus forms a septic etiology occurs due to embolization of bacteria, which triggers the thrombosis that becomes trapped within the cavernous sinus. Thrombus can propagate into the dural venous system As the lack of vein, as I told earlier, emissary veins are valveless, and the infection get trapped in the cavernous sinus. Coming to clinical features, headache is the most common symptom which occurs in 85% features, and it generally precedes fever and periorbital edema after by several days. The characteristic of headache is generally sharp, pain progressively increase in severity, interfere with the sleep, and it not relieved on taking any medication. It is usually unilateral, retroorbital and frontal areas are involved. Occasionally, it may radiate to the occipital region. Initial days of this cavernous sinus thrombus will be misdiagnosed as migraine headache. Uh, other features are fever is the most common symptom. Eye swelling that begins as a unilateral process within 24 to 48 hours spreads by the intercavernous sinuses to produce swelling in the other eye. Other clinical features are diplopia, altered mental status as drowsiness, confusion or coma rapidly follow the eye complaint as the infection spread to the meninges. Depressed mental status can occur in old ages. So eye findings are periorbital edema. Fundus examination is abnormal in two-thirds of the patient. Papilla edema or dilated tortuous retinal veins are noted in almost all two-thirds of the cases. Extra muscle weakness in form of lateral gaze palsy or full-blown ophthalmoplegia, drooping of eyelids, that is ptosis, dilatation of pupils, total nerve palsy leading to eyes down and out, uh, exophthalmosis and chemosis. Uh, Due to involvement of V1 and V2 segment, there may be hyper and hyperesthesia around the V1, V2 segment of trigeminal nerve. So these are the sensory nerve supply of V1, V2, and V3. V1 and V2 are purely sensory. V3 is both sensory as well as motor. How to investigate the case? Send blood culture. Two sets of blood culture should be sent before initiation of antibiotic, and they are positive in 70% of the cases. And blood peripheral smear picture may show increased WBC count, and lumbar puncture may be suspected for bacterial meningitis, may show predominant neutrophils, low glucose, high protein, and in 70% cases it may show culture positive also. Coming to the radiology, CT and MRI. CT shows non-contrast high density thrombus in the affected cavernous sinuses, only seen in 25% cases. Contrast enhancement, distended cavernous sinuses with not with a non-fat density filling defect. MRI show in T1 and T2, there is an absent flow void. Signal characteristics vary depending upon the age of the thrombus, but will be abnormal. Contrast enhancement or lack of it is a reliable indicator, as organizing thrombus can enhance. Diagnosis is mainly made by MR venography. This is a diagram. T1 with contrast and T1 contrast is showing enhancement of the affected extraocular muscles with proptosis and these are the lid edema changes. This is the cavernous sinus with um, increase in diameter, and this is a thrombus which is hypodensity. This is a image showing hypodensity of cavernous sinus.
Where is the hypodensity?
This
Hypodensity of, it's on the outer side of the ICA.
yes, yes.
But the arrow is exactly on that.
Yes.
That entire broad area. Top, you see the branching of the ICA, no?
Yes, sir.
Below that it starts. Little higher up here.
Yes.
Little more, from there it starts and goes all the way down along the ICA. That is a clot. That is like that side also. The side is right and left, and only one side.
This
It looks like it's there on both sides. Okay. Then
contrast enhancement on the right side, sir, and signal void sign will be there. And there is obliteration of internal carotid artery.
yeah, I see it's barely made up. Compromised. Okay.
Coming to complications, dural venous sinuses and cavernous sinus systems are valvulous. Communication between dural sinuses and cerebral and emissary vein can lead to meningitis, dural empyema, cerebral abscess. Propagation of infection via internal jugular vein can result in septic pulmonary embolism, pulmonary abscess, pneumonia, and empyema. Compression of internal carotid artery and pituitary gland will lead to stroke and hypopituitarism respectively. Coming to treatment and prognosis, antibiotic and antithrombotic are the treatment of choice. Mortality is up to 30%. Significant morbidity is also there in form of blindness, cranial nerve palsies. So, what are the empirical therapy we should give in the case of suspected septic venous sinus thrombosis? Injection vancomycin with either of injection ceftriaxone or injection cefepime. Ceftriaxone 2 gram 12th hourly, cefepime 2 gram IV 8 to 12th hourly. Cefepime may be considered in case of suspected pseudomonas. Pseudomonas should be used in if pseudomonas coverage is desired. Anaerobic coverage should be added if there is a source is from dental or sinus infection. IV metronidazole 500 mg IV 6th hourly to 8th hourly can be used. Minimum dosage for antibiotic is 3 weeks. And empirical anticoagulation therapy is anticoagulation therapy role is only used till there is a evidence of infection. It is not advised to prolong the use of anticoagulation in cavernous sinus thrombosis. If it's related to septic cavernous sinus, there is no studies or papers are suggesting to give longer duration of anticoagulation in cavernous sinus thrombosis.
Because how long it will be given?
If it is septic is a septic etiology is established, only we have to give till there is a source of infection is there.
So once the infection is treated, stop
Stop
anticoagulation.
anticoagulation. Coming to differential diagnosis, are carotid cavernous fistula, superior orbital fissure syndrome, meningoma, Tolosa-Hunt syndrome, lytic bone lesions, and cavernous hemangioma. Coming to Tolosa-Hunt syndrome, it is a idiopathic granulomatous inflammatory condition that involves a cavernous sinus and orbital apex. And it is a clinical, essentially a clinical diagnosis of exclusion. So how to diagnose this Tolosa-Hunt syndrome? Unilateral headache, it is the first symptoms which will appear. It may last for up to 30 days. And thereafter, there is a appearance of cranial nerve palsies. And this headache is mainly retroorbital region. So, how to diagnose this Tolosa-Hunt syndrome is mainly one criteria is there. International Headache Society has given a specific diagnostic criteria for Tolosa-Hunt syndrome. One is unilateral headache, and it should be a granulomatous inflammation of cavernous sinus, superior orbital fissure or orbit, demonstrated by MRI or biopsy, and paresis of one or more ipsilateral third, fourth, and or sixth cranial nerves, and there is a evidence of causation demonstrated by both of the following: headache has preceded oculomotor paresis by less than or equal to 2 weeks, or developed with it. Headache is ipsilateral to the granulomatous inflammation, or symptoms not better accounted for an alternative diagnosis. As I told earlier, features of orbital Tolosa-Hunt syndrome are episodic orbital pain associated with paralysis of one or more third, fourth, or sixth cranial nerves, which usually resolve spontaneously but tend to relapse and remit. It is typically unilateral, sometimes bilateral only seen in 4 to 5% cases. Constant pit behind the eyes that may begin several days prior to the ophthalmoplegia. Ophthalmic division of cranial nerve is involved in 30% cases. Diplopia, mainly third cranial nerve. Next is sixth cranial nerve, and last is the fourth cranial nerve. Horner syndrome may be present in 20% of the cases.
So nowhere they have mentioned V2 and second cranial nerve, no? So it's basically a cavernous sinus syndrome.
Cavernous sinus as well as orbital apex there.
There is in your list of conditions affected. Where is second nerve?
They have written this
It's not there in the
granulomatous.
diagnostic criteria.
It is the superior orbital fissure or orbit they have mentioned. A granulomatous inflammation.
But the nerves involved mentioned are
Only third, fourth, and sixth, and fifth also there.
Yeah, it is V1.
V1.
V2 is also not there, even though it's in the cavernous sinus, isn't it?
Yes.
And here in this, what are clinical features? You have not mentioned anything about optic nerve.
Yes.
So essentially, it looks like a cavernous sinus. This is what you're describing a cavernous sinus, isn't it?
Sir, superior orbital fissure.
Sir,
superior orbital fissure also it is.
Yeah, superior orbital fissure.
Superior orbital fissure.
In fact, this is superior orbital fissure.
Yes, sir.
Isn't it?
Yes, sir. Superior orbital fissure syndrome differential will be Tolosan.
Yeah. Cavernous sinus V2 also should have been there.
Yes, sir.
Okay.
CT may show asymmetric enlargement in the region of cavernous sinus on the affected side, with or without contrast enhancement. The secondary criteria are internal carotid artery narrowing, extension towards the superior orbital fissure, and orbital apex. MRI show contrast enhancement. MRI is essential for diagnostic evaluation. Enlargement of the cavernous sinus with abnormal tissue, that is usually high iso intense to gray matter on T1 and iso or hypo intense on T2, and strongly enhanced with the gadolinium. Focal narrowing of intercavernous internal carotid artery is also seen. This is a diagram which is showing hypo intense hypo to iso intense on T1 sorry T2 weighted image. This is the granulomatous. This is intercavernous outlet pressure.
This area looks abnormal. It's there's some increased hypotensity there. Yes. The vessels are also displaced. But that's all I can see.
Yes, they are showing its contrast enhancement on T1s. So coming to the treatment, there is suggested a glucocorticoid regimen is there. Prednisolone 80 to 100 mg for consecutive 3 days. Usually these are steroid responsive. Usually response within 3 days. If the pain has been resolved, then taper to 60 mg daily, then 40 mg, then 20 mg, then 10 mg. Every 2 weeks we have to reduce. Then the patient who are not eligible for prednisolone, second line of treatment will be cyclosporin, azathioprine, methotrexate, MMF, and infliximab.
Doubts? You can wait. Little late, no? Tell me the clinic which all are involved in superior orbital fissure syndrome, orbital apex syndrome, and cavernous sinus.
So the orbital apex will be second nerve, third nerve, fourth, and fifth, first branch of the fifth. Superior orbital should be D4, 6, and fifth nerve first branch. And superior orbital fissure will be third nerve, fourth nerve, and first branch of the fifth nerve.
What is problem with 6 nerve? You don't like
Fifth nerve. Fifth nerve. Cavernous sinus will be third, fourth, fifth, the first branch and second branch of fifth and sixth.
Okay. Then, so what are the differences between cavernous sinus thrombosis and regular CVT?
Because of the cranial.
No, in terms of etiology, in terms of treatment, how are they different?
Etiology, infections will be a prominent.
Majority will be infected.
Infection.
Whereas
Other, it will be mostly pro-traumatic stages.
that will be etiology
Etiology.
treatment.
Treatment wise, we need not continue antibiotics.
You know, for that reason, antibiotics will be the main line of treatment. And anticoagulation for short period. And clinical presentation, how will you differentiate?
Extreme headache will
Will be very
be
both.
both. Meaning cranial nerve involvement
Yeah,
and
so-
eye pain.
High times if you see with severe headache, you think
And
of
eye pain.
octopus will be there, emotion will be there, lead edema will be there, and cranial nerve signs will be there. If you see that presentation, you have to think of cavernous venous thrombosis. And it may be unilateral or bilateral. Any other doubts? Ask.
If no infection in cavernous sinus,